presentation will be fairly short because many people have covered the things that I was also going to talk about, so which is fine. I'm happy to get through it, and there's certainly some new things in there too, but I won't belabor things we've already talked about. So the prevalence and disparities, as we've been talking about them, I shall look down here, is that it's a number that we've just heard a couple of times, that people with severe mental illness, again using the Medicare, Medi-Cal designation, including schizophrenia, bipolar disorder, schizoaffective disorder, and major depressive disorder, have an excess mortality of 2 to 3 times as high as in the general population. And I also thought it was important, as we've been talking about this, to consider developmental disabilities, which are treated with many of the same medications as the disorders that I listed earlier. People with these disorders have a 13 to 30 year shortened life expectancy, and 60% of that is due to physical illness as opposed to suicide or other reasons. Some disparities are due to modifiable risk factors and lifestyle choices, but others are due to access and utilization and care provision. And these are the things that we've been discussing a lot today. The care provision in particular, when we think about medications for many mental illnesses, actually are going to significantly impair somebody's ability to live a healthy life as far as their physical health goes. So this is just a list that I didn't look at any journal or anything like that to come up with. I just this is what was off the top of my head in terms of what I found myself working as a psychiatrist that's done really the past, 8 years as a consultant for primary care. What I've seen are the biggest issues. It's a confluence of provider, client, and system factors. And as Dr. Miglani had said earlier, I think that time is certainly not our friend when it comes to treating people in general, but particularly people with disabilities, emotional and psychological disabilities, because there already is such pressure on your time, especially for a primary care provider, for a specialist, that if they feel like there's going to be some barriers to that communication, then there's stigma right off the get-go, and because they're already thinking, this is going to take more time than I have. I have 10, 15 minutes to see this patient, in addition to do my charting, ordering whatever labs that I have to do, and putting in whatever referrals need to be put in, whether to behavioral health or otherwise. So along with this is the information systems that we use. They don't communicate with each other well. And along with that, of course, we have privacy laws that prohibit us from sharing information without very airtight releases of information. And so, like I was saying earlier, the more of these that have to be signed and passed around and faxed between people for the protection of patient privacy, but unfortunately they do work against being able to coordinate care effectively. Along with that is funding streams. There are 2 very, very different systems in California. The federally qualified health centers that are primary care and other specialty services, and then there's behavioral health. And the money is coming from 2 very different sides. And so it's not only that we have privacy laws, but we also have very different computer systems, and there's just traditionally been very little impetus for sharing this information. There are more barriers to sharing it than there are incentives for sharing it, actually. I hope that that will change going forward with the Affordable Care Act and the need for more systems to be talking to each other. Right now we're in our infancy. It's almost like if people remember back in the early days of Apple and Microsoft, where if you wanted to get something from one to another, you just couldn't, because they were competing against each other. And that's kind of where we are in terms of information systems. We'd all love it if down the line we can have an easy tablet that would work for lots of different settings and situations, as long as things are taken care of. But it's quite complicated, especially with our current laws. Substance abuse is a whole other realm that has even more strict And as we learned from Dr. Pading, substance abuse can really inform somebody's health in so many ways. And then the last thing was stigma, which we've talked about a good bit today, but it's provider to client in some cases, and then it's also client to provider, because they might have had bad experiences to begin with or over their lifetime, and they want to avoid feeling re-stigmatized, or they're wary about it. That feeds also into the self-stigma that was spoken about also, where you don't want to confront the fact that you may have some difficulty or want some help. It may just be hard to make that leap, or to make the changes that are recommended of you, or you just don't want to hear it again. So there's on multiple levels, people tend to avoid seeking out help until it's later than would be optimal in many cases. We work in sort of a crisis-driven model a lot of the times. And so, but I do want to be hopeful here. The current efforts within San Francisco Department of Public Health for integrating these systems so that there is easier communication are attempting to look at releases of information and ability to share information, at least between more systems. You can't obviously share, you have to protect privacy, but at least if a primary care doctor is working with a therapist or a psychiatrist and still under DPH, for those two to at least be able to talk to each other freely. So that's one thing that they're working on, but then the concept of a health home where there are nurse practitioners and more of the, I'm not sure about the number currently. I think that there's in 4 CBHS is Community Behavioral Health Services, clinics in San Francisco. And so they're gonna be part of a health team. And so that's both having some physical health providers in the mental health clinics, but also having much more mental health capabilities within the primary care setting. And that's sort of what I mostly do, is do consultations with primary care doctors to help them to manage behavioral health, psychiatric issues for a patient who wants to just be seen in primary care. They don't want to go, to clinic and that kind of thing. So telepsychiatry, it's in its infancy. It's been around, but primarily in rural areas. But right now, we can offer it in a limited number of primary care clinics in the community. Eventually, I anticipate, just like in the private sector, that you'd be able to see a psychiatrist or a therapist online if that's your choice. And that way, it removes at least that barrier of having to, go somewhere, get parked, spend the 30, 45 minutes, with your therapist, get back to work. These are things that in a busy world, at least is an option. Patients that I've worked with that have done it have enjoyed it. They find it convenient. I don't think it's a substitute. I still like to see patients in person, but not. But if it's a check-in or something like that, then it actually works quite nicely. They're doing smoking cessation groups in lots of the primary care clinics currently to help address, we were talking about schizophrenia and smoking and how there's a very high concordance there, to try to address that at least some way, probably in a harm reduction manner. And then, as I said earlier, information sharing. I will touch on something that Dr. Miglani will talk about a little bit more. We just did a psychiatrist survey in CBHS, and very few of the psychiatrists currently are comfortable prescribing medications that for treating physical illness. In other words, something for cholesterol or something for blood pressure, something for diabetes. They want the primary care doctor to be in charge of those. And it's understandable, it's long held that there's scope of practice. It's one reason that primary care doctors have traditionally been very wary about prescribing psychiatric medications to their patients without substantial backup, and even in some cases they just won't do it. And it goes both ways, and so you really are making it, you're keeping the walls pretty tight. I think the scope of practice will have to be looked at if we want to see more of that. But I thought that was an interesting finding. They are comfortable. The good news is that they're comfortable like with prevention counseling and things like that, and they do try to address smoking and other health concerns, but in terms of actually providing a prescription or care, that's very unusual currently among psychiatrists, and vice versa among primary care docs. So that's really my whole presentation. Happy to take questions, or we can just keep moving, whatever.
The young lady up front.
My name is Janelle, and I'm the staff attorney for People with Disabilities Foundation. And I just wanted to touch upon something that you mentioned that we've had issues with regard to provider to client stigma. We had a client recently who we represented in a Social Security matter who had a diagnosis of psychotic disorder and NOS. And while we were representing him, he developed scoliosis. So we made arrangements for him to see an orthopedist. And on the day of his appointment, he called us in a panic because the doctor didn't see him. And apparently he was ushered into the treating room, and the doctor never came into the treating room. And so we investigated the matter a little bit, and it turned out that on top of his chart, someone had written schizophrenia in black letters. So the orthopedist looked at the chart, set it down, and left the office. So those are the kind of issues that we're dealing with, that less about stigma between psychiatrists and our clients, but other physicians and our clients.
Mm-hmm.
So just wanted to mention that.
And it's sad to hear that. I don't encounter it that much because I work with, to me, a pretty great group of primary care doctors and occasionally specialists. A great surgeon that's really open-minded and good is one of the best people in the whole world. They can do things that very few other people can do. But many surgeons, that's not their specialty. that's not where their strengths are, and so that should certainly be brought to people's attention. And that surgeon needs a little bit more training and education, and because they also are fairly responsive usually. And I'm sorry that happened, but I hope that that's not anywhere near the norm. Yeah.
I also had a quick question for Dr. Pading.
Mm-hmm.
With regard to substance abuse, if the goal is overall health, mental and physical health, what is the current research with regard to whether the abstinence model or harm reduction model is better?
Well, I mean, I don't know if people understand the question, so it's a question whether you should, if you have a drug problem, whether you should completely stop, or if you won't stop, should we tolerate you not stopping, and which is called harm reduction. And I don't know if there's a better or not better. This is really what's appropriate for the client. I have some clients that when they are with other people that have stopped using or drinking or drugging, they feel more support, because there's, just to have somebody sometimes coming in a room that looks like they're drunk or stoned, it could be a trigger for people. So I look at it more when I work with my clients is, what's best for them. And certain systems, this is more of the historical thing that I've been talking about, have evolved either more abstinence-based because of their recovery model, or if they've been associated more with community mental health, more of a harm reduction base. So it depends on who you're serving, the goals of your program, and and what the individual right in front of you needs. So I think it's sort of a false dichotomy to say one's better than the other. They both are good, and applied to the wrong person, they could both be bad. So what does that person need? And that's the best treatment. And that's the hard part, is getting everyone to get individualized care. So how do then we assess and train everybody to receive that assessment? And that's kind of, I think, the message that we want to do, is that let physicians know about this intersection of health, so that when they're thinking about diabetes or their drugs, that they're also asking, have you ever been depressed because of your diabetes or because of your drugs? And the same thing on the other end, it sounds like we need to train psychiatrists to say, certain of my medicines might make your diabetes worse. Oh, by the way, let's check your diabetes. So it's a two-way kind of intersection here. But I want to just actually leave with one last message and hope to get this one out, which is, as you can see from Dr. Holt's example, there's a lot going on in San Francisco and in the state and in the nation regarding this integration, bringing the house of medicine together. And there's actually a lot of pressure to bring medicine and behavioral health together, because if we don't, people won't get their funding for clinics and the doctors won't get reimbursed. There's actually financial incentives now. There's also financial incentives that everybody should have health. We actually just recently passed several laws in California which will make California and the private insured plans, the essential health benefits, have the most substantive mental health and substance abuse benefits pretty much in the country. And in the public sector, namely our Medi-Cal sector, our expansion benefits are probably the best anywhere in the country as well. So California as a whole has enough money, and there's pressure pulling together the medical system. What I really think is missing in all of this is still training us as consumers, as clients, as peers, how to either access and get the health that we deserve, work together to demand or motivate clinicians to provide the health that we deserve, and then working, with clinicians in a new and different way. So we can get our doctors and nurses to do something, but again, as peers, if we're not really sure how to play a part in this new kind of, it's called collaborative decision making. It's the new model, and it's based on evidence. It's based on that if you tell somebody, look, here's your choices. You can take this pill, or you can get this shot for your diabetes, that they'll have a choice and their chances of complying will go up. But if they don't give them a choice, usually compliance, which is really half the battle. It's getting people to take the medicine, or to do the exercise, or to eat the greens that your mom says that you're supposed to eat. That's the whole thing. It's these behaviors that we all know that we should be doing, that I don't do. My kids are selling chocolate bars in school, and who's eating them all up? It's me, right? We all have these little things where we know we can improve. But how to be better at advocating for our care and be better about our self-care, that's the challenge of the next century for health. And that's where I hope that, again, our peer colleagues will show us the way, as well as our physician colleagues will provide us the opportunity, the information that's coming in an evidence-based way. All I know is Mediterranean diet, greens and nuts, greens and nuts. That's my mantra right now. And chocolate? I know.
Dark chocolate in small quantities. And I have a couple of comments just in response to that. First of all, I think you make an important point that a lot of the issues we're talking about are by no means unique to mental health consumers. I mean, we all have difficulties, as you say, complying with what we know we're supposed to do. We all have anxieties about going to see a physician from time to time. That's why we have white coat syndrome, which is what makes your blood pressure shoot up 10, 15 points when you go see a doctor versus what it is the rest of the time. I mean, these are things that a lot of people deal with, and I think that it's important to acknowledge that, so that we get away from that idea of us and them. We're all in this together, and we're all dealing with situations that are very similar. And to the subject of harm reduction versus abstinence, I wanted to comment because I think a lot of people are aware of what the benefits of abstinence can be, because that's been a model that's been highly touted for many, many years. Not everybody understands what the benefits of harm reduction can be. The benefit of harm reduction is that it provides an option for people who aren't willing or able to discontinue the use of their substance of choice at this time. There are a lot of valid reasons why people use substances, for example, or why people self-harm, why people do these things. These are coping mechanisms that, for whatever reason, work for people to the degree that they've become dependent on them. I hate the term something being a crutch. I've heard that many times in my life, that alcohol is a crutch, because I think it misses the point. Who needs to use a crutch? Somebody who's having difficulty walking. And so if someone is able to practice harm reduction, if they're given the option that we can look at making your use safer, we can look at tapering off over a long period of time. Let's look at the benefits of continuing to do what you're doing the way you're doing it versus the benefits of changing. if we can look at those things and work with someone, and that's something that I do in peer counseling regularly, these are things that give people options, and they allow someone to take control of their life in a way that they may not have been able to before. And that's, as you said so eloquently, it really depends on the individual. There are some people who are going to end up being abstinent for the rest of their lives, and that's the right choice for them. There are other people for whom harm reduction is a great option, and a lot of times it can be very beneficial to learn how to do something in moderation over time, and that can be very empowering as well.
I just wanted to comment further on the problem of barriers to accessing healthcare. I know of an individual who has a diagnosis with of a psychiatric disability, and she also had a toothache. So she went to the dental clinic to seek treatment for the toothache. She filled out, it was her first time at the clinic, so she filled out the initial questionnaire, and on that questionnaire it asked what medication she was currently taking. So she listed all the medications she was taking, including her psych meds, Seroquel. She was seen that day by a dentist, but it was determined that she needed to have a tooth extracted, and so an appointment was set up with an oral surgeon. When she went back to see the oral surgeon, they refused to do the surgery and told her that she needed to bring her entire psychiatric chart back to the dental facility. Now, this person has anxiety issues, and she could have handled it a couple of ways, but on that day she decided to stand up for herself and say, no, I don't see what my mental health has to do with my toothache. And so the surgeon backed down and then said, well, we just need a release to do the surgery from your primary care physician, and they backed down on the position of needing to see the entire psychiatric chart. But that type of barrier, if she had been in a different frame of mind that day, she may not have felt strong enough to stand up for herself, and she might have just gone home. So I'd like some comments on that.
I'm wondering what the panel thinks about this kind of overt discrimination happening now, the year 2013, here in the San Francisco Bay Area. On the one hand, we're talking about San Francisco and other places are really moving forwards with integrated models and telephone appointments with psychiatrists and peer-led groups, which is as beneficial as anything else, or even more so. And yet, on the other hand, we've just heard two stories, one with the orthopedist and now a dentist here. Is this overt, what I call overt discrimination, something that is just going on side by side with all these advancements and ideas of, the home health homes? Is this what is the reaction of the panel to this kind of thing? It doesn't seem, or is it so random?
Yeah, I think it's better in San Francisco than it is elsewhere. Certainly, I think San Francisco has really made a concerted effort to implement a recovery model and harm reduction in a lot of city-funded programs. That said, as much better as it is here than elsewhere, we're not totally there yet. I mean, there are still people that need to get the message and who need to be educated in terms of stigma reduction. I mentioned that I'm part of Speakers Bureau Solve, Sharing Our Lives, Voices, and Experiences. We go out into the community and we do presentations on stigma reduction to all sorts of different audiences, and included in those, we speak to medical students. We speak to physicians. We talk about this stuff, and we open the dialogue around it, because there is work that needs to be done still, regardless of how great San Francisco might be in comparison to other places. There's still definitely work that needs to be done.
I just say that throughout the state, the issues of stigma and discrimination are pervasive, and they're very hard to address. You're really talking about culture change, education, and a sense of awareness and exposure. And I think that there's just many things that have kept those barriers up. I'm actually going to address something controversial because I do wonder about it and address to maybe some of our lawyers whether even the way that we've framed mental health confidentiality or substance abuse confidentiality itself is stigmatizing by saying that mental health is not part of regular health, that it's something that's different, that has to be protected. Aren't we saying that, well, it should be hidden and maybe even a sense of shame around it? So I'm trying to find the balance here from a perspective of, again, as you're saying, the benefits of for example, NAMI speakers or peer speakers speaking about their health as a process of one of sharing and recovery, and yet hiding that recovery because of the fear of sharing. And so I understand that we're trying to look at, it's a historical thing and we're trying to protect, but it's a fine balance here, and I'd be interested in that because I think part of that is at the root of some of the medical stigma that
I agree. We were actually talking during the break about HIPAA regulations, which is the Health Insurance Portability and Accountability Act, which especially when it comes to mental health issues, can be really counterproductive. I was talking about one specific example that we've had at MHASF in terms of using photographs at conferences and whatnot of people who identify as mental health consumers. And we are not legally permitted to use those photographs, even with the permission, the express written permission of people, because if they identify as a mental health consumer, it is not legal for us to do that, is our understanding of HIPAA regulations. And that sort of implication that we as consumers, as peers, are not able to give informed consent by virtue of our diagnoses is really troublesome and problematic. This is something that we've investigated and has been ongoing for some time. So if somebody has updated information on that, I would love to hear about it. But it's yeah.
You're saying that even with a release from the patient, it's still illegal. Well, it's a surprise to me. But let me say this about the two conflicting sides. It is true that in the employment arena, if word were to get around wherever it is that an individual works, or whatever kind of work an individual does in any geographic area, it may lessen his or her chances of getting a job. I mean, that is a reality of the workplace, and things haven't changed that much. And I'm not talking about Mental Health Association San Francisco. There are small businesses where there's a lot of interaction with the public and the worker, and it is an area where I can see why an individual would not want to tell someone, so an employer or prospective employer may find out that they have schizophrenia, because frankly, because of stigma in another way, that is scare away the customers. Now, I'm not saying that's true. The customers would be scared away, but there is that fear in the workplace.
But it's up to the individual whether or not they choose to disclose that. And
absolutely.
that's what we're saying. I mean, it's a decision that ultimately needs to rest with the individual. And
Yes.
HIPAA laws don't always permit
Yeah.
that.
Yeah, I was just thinking of a way where you'd really want to have someone who's looking for a job and had to give one up because of their schizophrenia, maybe would not want to put down reason left employment, schizophrenia. That's just something that comes up. From time to time, I've seen it with some of our clients when the Social Security Administration, you have to tell them why you left, and it needs to be disability related. But then again, are you really going to tell an actual employer? Do you want them to know that they have schizophrenia? Because how is that going to affect your chances of getting your next job?
You're not going to get it.
That's right. And it's something they're
I just think something, though, to interject is that certainly the stigma still exists, and it is causing problems. There's no doubt about that, and that there's a long way to go to decrease that stigma if we draw the parallel to LGBT rights or even to civil rights, that it really was people who were experiencing the stigma and the discrimination being peer advocates and sticking together and advocating for themselves, being more visible. This is a two-way street here. People are much less likely to stigmatize maybe after they had this experience with a woman taking Seroquel. If things went fine, then maybe they won't be so averse to treating somebody that's taking Seroquel in the future. The same thing with this. So this is not to say that there's not huge problems. And they probably are better here than in San Francisco than in most other parts of the country, you might even probably say. But if there's not more, and it goes along too with what Dr. Pading was saying, was that as long as we do have these fierce, intense privacy laws where people do feel like, oh, this is my secret, and I'm not going to tell anybody, then I don't know that we're going to make a whole lot of progress if it's not working in both directions.
So here's my my hope or my aspiration. At the turn of the century, it was tuberculosis, and individuals with tuberculosis were swifted away into asylums in the mountain. In the 70s and 80s, we had the worries of HIV, and now Magic Johnson is the owner of the maybe National League pennant Dodgers and has a very successful career. My hope is with mental illnesses as well, is that we'll overcome, at least in the House of Medicine and Healthcare, a sense of equanimity that, to see these on par with mental and physical disorders. That is the law, by the way, with mental health parity, is that at least financially, there's an obligation to treat them the same. And again, I hope in terms of the level of care, that same parity will exist. So that's my hope. Don't know how many decades it'll take to get there. So you hope that you'll stay there at the end when we do. So.
Okay, let's move on to
Even there was actually a question here, real quick, okay?
I just, I'm a primary care physician with DPH, and I do half a day a week at the Tenderloin Outpatient Clinic, which is a mental health clinic a few blocks from here. And I've
And
been
a great one, I'll add. Yeah.
for 10 years.
We love Dr. Zevin.
I also work at Tom Waddell, so Dr. Zevin. And I think I totally agree with Dr. Pading and have for decades on, the triple threat or whatever it is. I think there are also other reasons for the disparities. We have a very difficult system with the SPD Medi-Cal managed care lately, having to go to San Francisco General. I've had 2 people refuse colonoscopies, even with escorts. So that's another difficulty. There's also the issue of many people, if they have severe mental disorders, they are poor. They're going to be on SSI. In San Francisco, oftentimes that means they're going to be in an SRO, single resident occupancy hotel, which means oftentimes they're not going to get much physical activity. They're going to be smoking. They're also going to be eating a ton of fat and sugar. So you have that deconditioning and overweight. You also, if you don't value yourself, you're not going to be motivated to make the huge changes necessary to improve your physical health. So I just wanted to add that as another barrier, and also add that I teach medical students, and I do teach them a lot about mental health and respect and stigmatization.
So I
Thank
think you're
you.
pointing to things that these sort of circles, I'm just sort of imagining where people are lying or falling out. I mean, one is, again, we want collaborative care in the office between the doctor and the patient, but then there also needs to be collaborative care between a community clinic and its community, and around the Tenderloin Health Clinic, for example, or others, there's things like full service partnerships where we're meeting people where they're at. Always it's a conversation of meeting clients where they're at, the health system, and the peers and the clients. And some can make it to clinic, some can't, but I think, again, we're looking from a public health perspective. It's not a one-size-fits-all. It's not abstinence, it's not harm reduction, it's not in the clinic, it's not out of the clinic. We need to have a flexible set of options of something so that people, that whatever it takes to get people healthy, we can get there. There's the balance of the resources, but where there's a will, I've seen many things in our city. There's also a way. There's providers that want to do it. There's consumers that want to reach out, and somewhere in the middle, there has to be a rational voice to say, look, let's just go ahead and do this. You know, it didn't work for this person that went to the dentist, but you know, it's going to work for the next person, and that's really the hope and vision that I would hope that we would all be able to carry forward.
And there are some terrific programs right now that are addressing some of the specific concerns that you mentioned. For example, just a quick shout out to the AIMS project, the Alleviating Antipsychotic-Induced Metabolic Syndrome project, which meets at Tenderloin Outpatient Clinic and is addressing some of the nutritional aspects of what you were talking about with SRO living and that sort of thing. So great stuff.